Hi, Steve. It's good to see you here. There wasn't much notice for this, I'm afraid. Uh, I'm a little disorganized. I was busy all day with something else. And so I do have three relatively short shows that are planned. This is the first of them, and it's about a failed healthcare system, okay, and what to do about it. I'm going to present a piece by Robert Kuttner. It's about the healthcare system in Massachusetts. And you should be seeing it right now. Uh, I picked it up at Portside, but it was originally at the American Prospect, where I often pick up things from also. But the subtitle of this is Why Even an Elite Boston Hospital Can Feel Like a Makeshift Infirmary in a War Zone. February 6, 2024. And this is the Shapiro Building at Brigham and Women's Hospital in Boston, which, by the way, is a world famous hospital, as Robert Kuttner says in this. I'll just read the first sentence. A couple of weeks ago, a good friend found herself in the emergency room at one of our world class hospitals, the Brigham and Women's Hospital in Boston. I'm a little familiar with that hospital because I wrote about the Partners healthcare system, and that hospital is in the Partners healthcare system. I read about it in a knowledge management context where uh, I wrote about it, I should say, in a knowledge management context uh, where they were doing something really excellent from a knowledge processing point of view. Anyway, going on with the piece, after emergency surgery, the medical team decided to admit her for at least another day to monitor her recovery. What she encountered next was something out of a makeshift battlefield hospital, as rendered by Hieronymus Bosch. I don't know if you're familiar with the Bosch paintings. The uh, Anyway, they were really like nightmares. There were no beds available in the patient rooms, so admitted patients were being stashed in beds laid end to end in the emergency area. A bit of delay getting a bed is not unusual, but in this case, there were seriously ill admitted patients in 73 beds crammed into the emergency area. They had no privacy. Many were not masked. The beds were around an overwhelmed nursing station where a couple of nurses were mainly dealing with new patients. This makeshift field hospital was so large that it was sectioned off into sub areas that had been given Boston street names. My friend was in the Exeter Street area so that family and physicians could find them. What the hell? In exploring deeper causes of backup, you encounter a story of multiple cascading failures of our health system. And no, it doesn't have a lot to do with COVID overload. There are a few patients hospitalized with COVID, at least right now at that hospital. The immediate cause is a shortage of skilled nursing facilities, rehabs, and home care options into which still impaired patients can be released. So patients are kept in acute care hospitals because there's no place else for them to go. This means the normal process of beds opening up as patients are discharged backs up and bogs down. This is completely at odds with deliberate incentives in Medicare and private insurance plans to get patients released from expensive acute care hospitals as soon as medically feasible. But yes, around here, they're sort of, first of all, they're reluctant to admit you to the hospital, but even when you get in, they want you out as quickly as possible. There are approximately 1,200 such patients currently occupying hospital beds in Massachusetts. In December, according to the Massachusetts Health and Hospital Association, 44% of hospitalized patients awaiting discharge to a skilled nursing facility were waiting for 30 days or more. They were basically in residence at a hospital, taking up scarce beds at the most expensive venue for care, and hospitals do not have rehab staff. And I can't imagine what the patients were getting billed for being in the hospital for 30 days. That must have been really astronomical. Dig deeper, and there are the multiple causes of this mess. There's a severe shortage of slots in skilled nursing facilities. Much of this is driven by a shortage of staff, mostly nurse aides, known as certified nursing assistants. To be precise, there were incredible 6,900 unfilled vacancies. Why the staff shortage? The biggest single reason is that the work is hard and the pay stinks. Okay. A CNA typically earns between $18 and $21 an hour. Given Boston rents, this is not enough to live on. People trained as CNAs are working at other jobs. Many others work in non-clinical jobs at nursing homes, could be trained as CNAs if the pay were decent. The staffing shortage, in turn, has caused at least 20 skilled nursing facilities to close since the start of the pandemic. There are now 3,000 fewer beds in such facilities available than in 2020. Many nursing homes that are open are running at about two-thirds capacity and not accepting new patients due to staffing shortages. Their business model calls for them to operate at capacity, so they are losing money and at risk of closing. In addition, consolidations and mergers have cut the total number of inpatient hospital beds. These include the ongoing collapse of the Steward Hospital chain, which converted a nonprofit Catholic health system to a for-profit one and then ran short of operating money after being milked by a private equity fund owner. There it is, private equity. It's awful work. It's a whole of things. Another prime cause is the evil of Medicare Advantage, the privatized for-profit system that leeches off Medicare. As the Prospect has reported, Medicare Advantage pretends to increase coverage, but because Medicare Advantage programs are so intensely managed, quote unquote, to deny needed care, they're great when you are well, but not when you are sick. While conventional Medicare provides 20 days coverage in a skilled nursing facility at no cost to the patient, and another 80 days with a copay, Medicare Advantage plans often refuse to pay for post-hospital nursing care at all, according to a report by the HHS Office of the Inspector General. The Massachusetts Health and Hospital Association's own report puts insurance denials for skilled nursing care as the top cause of the crisis. The further problem is that health plans often don't pay for case managers. An elderly patient facing discharge from a hospital with multiple conditions, often complicated by dementia, is not competent to manage her own case. When a hospitalized patient cannot safely go home, three options are a skilled nursing facility, a rehab, or home care. All are short of staff, likely because of profiteering and inadequate pay. Incidentally, the Republican policy blueprint for 2025 includes a suggestion to make Medicare Advantage the default option for all seniors coming into the program. Yet another problem is the shortage of physical therapists, key staffers, and rehabs. A decade ago, most licensed physical therapists had BA degrees. Then their professional association, in order to raise pay, launched a successful lobbying campaign to require doctoral degrees. Result, a physical therapist shortage. Jessica Pastor, the director of external communications and media relations for Brigham and Women's Hospital, responded to my questions in an extended email, pointing out there's only so much the hospital can do, but that they have actually cut waiting times for inpatient beds by 33% over the past year. Their strategies have included better coordination with nursing homes and home care options, as well as improved discharge planning. The system is now so bad that its structural failures affect even the most privileged among us. Where might some real system wide progress be made? Most long term nursing home patients are on Medicaid, which pays nursing homes at a far lower rate than Medicare, even at capacity. During the pandemic, emergency federal and state aid financed extra help for nursing homes provided. Much of it would be passed along in higher wages. That aid is now finished. It would help if Medicaid paid at the Medicare rate, with the increased reimbursement earmarked for wages. We also need real leadership from Governor Maura Healey. 3 weeks ago, the Massachusetts Health and Hospital Association, working with Blue Cross and the state's Secretary of Health and Human Services, Kate Walsh, came up with a palliative plan that helps only marginally. Blue Cross will streamline approvals for nursing homes, and nursing homes will stay open weekends to process admissions. Other insurers were not party to the deal, and an indication of sheer cynicism, Steward Healthcare was. Steward Healthcare that was already failing. Governor Healey needs to make better and better targeted state reimbursements a budgetary priority. SEIU Local 1199, representing nursing home workers, argues the solution is both better pay, training, and reimbursement, and also incentive bonus payments for nursing homes that score well on staffing and low turnover. This syndrome is simply not a problem in nations with universal healthcare systems. Ours is a systemic failure in the broadest sense. Think of it as a supply chain crisis. It won't be fixed piecemeal solely by better pay and more training for CNAs, so that would sure help. It certainly won't be fixed by adding more refined incentives for cost containment, which has been the obsessive focus of health policy for decades. The shortage of post hospital facilities and the backup effect on acute care hospitals can be fixed only in the context of a universal system, which includes planning at every level. That means planning for facilities, for needed levels of health professionals, their training, and their compensation. The mess is a vivid example of how reliance on commercialized healthcare with piecemeal regulation has failed and backfired. Single payer, long the goal of progressive reformers, is only part of it. We also need decommercialization and comprehensive planning, which is only possible in the context of a universal and non-commercial system. At 4 a.m., with no prospect of a room in sight, my friend gave up on the Brigham Field Hospital and decided to risk her health and go home. She is a professional. She's married to a doctor. They figured out that if anything really bad happened, they could go back to the ER. In sum, the system is now so bad that its structural failures affect even the most privileged among us. Some rich people get boutique medicine for their outpatient needs, but Brigham and Women's is where Boston's elite go for quality and patient care. If that's a mess because of deeper systemic problems, there's no place to buy your way out. My friend, as it happens, has long been a single payer advocate, but as the systemic failure compromises the health of well off conservatives as well as progressives, maybe that will provide some push or momentum for change. Note this piece is about Massachusetts. The problem is national. A follow-up article will look at trends nationally and federal policy. So that piece really reports, on a horror show and points out that it could be fixed partly with Medicare for all, but there also has to be extensive federal planning to make sure that the supply chains, are adequate so that hospitals, are not overloaded, so that hospitals are no longer looking for profit. They have to go back to a nonprofit system. Lots of things have to be changed. Now, I ask you, can those things be changed with the system we have now? Can they be changed without a bunch of legislation which addresses more than Medicare for all, but the whole healthcare system? Now we know, or I know anyway, okay, that Medicare for All can cut our expenditures from 4.3 trillion a year to roughly 2.2 trillion per year. I know that, okay, and I expect that, but there also has to be improvements in facilities and improvements in the supply chain of the kind that Kuttner talked about. How are we going to get those bills through Congress? The answer to that question is the answer that I often give here, that I freely give here, that I'm going to continue to give here. And that answer is to dump the corruption in Congress and dump the corruption in the executive branch and dump the corruption in the Supreme Court, dump the corruption all over. What needs to be done is to replace people who are taking big money in their positions to maintain also their positions and to stay in their positions over a period of time. Hey, Dolores, how are you? And so uh, that is the remedy. It's to dump the corruption remedy so you get a whole set of new people in, not beholden to the special interests, not beholden, okay, to big money, so that they will be vulnerable to the desires of the voters, so that they won't be looking to protect the vested interests in the healthcare industry. With regard to the healthcare industry, in order to make it a success, we need something like a slaughter on 10th Avenue. I'm sorry about uh, the reference to that piece, but I just had to do it. To rebuild, we need a slaughter on 10th Avenue, okay, in the healthcare industry. And that's my message for this particular stream. I'll be back, okay, in a few minutes with another dump the corruption scheme, also about our healthcare system, but about another aspect of our healthcare system. So hang on. I should be back at 8:15 with a fresh stream, okay, on that particular subject.